Today I'll be talking about the outcome measures of assessment for oral health and dentofacial aesthetics in patients with orofacial clefts. And this is the outline for my presentation. Orofacial clefts are the most common craniofacial anomalies worldwide, with a prevalence of 1.2 in 1,000 live births. Children with orofacial clefts present with a wide range of challenges: the psychological impacts of the cleft on parents, challenges with feeding, with speech, auditory function, oral health, and dentofacial aesthetics, amongst others. These challenges underscore the need for a multidisciplinary approach to care. Thus, a multidisciplinary approach is considered the gold standard in the management of these patients. In the light of this, we want to ask, how do we assess the quality of care provided? In the words of Stephen Covey, a world-renowned author, beginning with the end in mind, which simply means bearing the outcome of any procedure you want to carry out in mind before you start, is one of the key habits of highly successful people, individuals, organizations, or even processes. Therefore, it is very important that the multidisciplinary treatment planning for patients with cleft lip and palate is carried out with the expected treatment outcomes clearly in mind. Before we go further talking about treatment outcomes, I want to quickly review the cleft volume in Nigeria. A recent study, a study carried out in 2014, which is the most widely quoted study till date on the prevalence of clefts in Nigeria, reports that we have 5 in 10,000 live births of patients born with clefts, orofacial clefts in Nigeria. That particular study reported that there are more males than females, significantly more unilateral left clefts than unilateral right clefts. Cleft palate shows significant gender difference, with females being affected more than males. Associated anomalies were observed in 4.7% of the cases seen, and familial history in 10.4% of the cases seen in that particular study. How has comprehensive cleft care evolved in Nigeria? The last decade has witnessed a rapid expansion in comprehensive cleft care delivery in Nigeria. This is particularly due to the efforts of Madri, which has extended its sponsorship beyond surgical care to include other aspects of cleft care. So many centers now provide, in addition to surgery, they provide orthodontic care, speech therapy, feeding supplementation, amongst others. This rapid expansion in the scope of cleft care provided by different centers across the country, and indeed across different centers in West Africa, has led to an increasing need to audit the quality of care provided. And this takes us straight to outcome studies, because outcome studies enable us to actually audit the quality of care that we provide. What are outcome measures? Outcomes can simply be defined as attainment or lack of attainment of specified goals of treatment. Each procedure we carry out as cleft care providers, as different members of the team, for every procedure that we carry out, we have an intended treatment outcome. And whether or not we attain those outcomes that we have planned from the beginning, irrespective of what aspect of care we provide, we can use whatever results we get and measure that against an established outcome to know whether or not we have provided care to that extent to which we intended to, or to that gold standard that is expected worldwide. Why are outcome studies important? In the fields of medicine and dentistry, continued audit of performance, and in particular clinical outcomes, is essential in order to maintain and continually improve patient care. These outcomes also help to compare different types of treatment modalities across centers. What are the features of an ideal outcome measure? It should be reliable, which means it should be consistent and reproducible. So no matter the amount of times you use that particular outcome measure, it should be able to give you the same results. It should be valid, simply meaning that it should be able to measure what it claims to measure. It should be easy to learn and simple to use. And so outcome measures should be as uncomplicated as possible. Outcome assessments may either be clinician reported or patient reported. Majority of the outcome measures that we have used historically, that were developed in the past, were clinician developed outcome measures. And these outcome measures were directly based on either quantitative or qualitative assessments carried out by the clinician. But more recently, as medicine and dentistry evolve, and we all know now that the emphasis now is on quality of life, patient-reported outcome measures are becoming more and more important. And so, although emphasis were not placed on these in the past, we now have also more patient-reported outcome measures. Cleft care, because of the complexity and the multidisciplinary nature of cleft care, there are challenges in developing outcome measures to assess cleft care, and some of the reasons include those listed above. There are a large number of outcomes. For speech, you have speech outcomes, you have the outcomes, aesthetic outcomes for surgery, you have for growth, you have for auditory, for hearing, auditory, you have even for psychosocial development. And so for all the different members of the cleft team, they all have outcome measures for the different aspects of care that they provide. And so the question, each specialty presents with multiple methods of assessing care. There are also different types of clefts. You cannot use the same outcome measures for unilateral cleft lip for a patient that has unilateral cleft lip and palate, and a patient with bilateral cleft lip and palate will present with slightly different outcome measures, even in terms of simple measures as even the lip repair. And so all these have combined to increase the complexity of assessment for outcome measures for patients with clefts. To date, outcome measures or indices found in the cleft lip and palate tissue are designed for use with unilateral cleft lip and palate patients. So in patients with unilateral left lip and palate are taken as the standard patients units of measure, because those patients have both cleft lip and cleft palate. And most of the outcome measures that have been developed around using unilateral cleft lip and palate as the prototype for those measures. This is because UCLP involves both care of the lip and palate defects, and is likely to give an indication of the outcomes across the entirety of care. What other challenges do we have when we talk about outcome measures for cleft lip and palate? Identifying which outcomes are important, how these outcomes are defined. How do we define the outcome that we refer to? Because the child with cleft is different from birth to adulthood, at what point should they be assessed? So even if you determine what outcome assessments are important, at what point should they be assessed? If you want to assess maxillary growth, which I'm going to talk about in a short while, for instance, at what point do you want to assess that in a child? Or you want to assess the success of the primary surgery in the cleft palate repair? At what point would you want to assess that to know whether or not that surgery has not impaired maxillary growth? How should they be measured? What indices should they use? Should you use in measurement? Which tools or methods? Do you want to use qualitative or quantitative tools? From whose perspective? For a long time, we talked about the clinician's perspective. Now, we are gradually placing more emphasis on patient's perspective. So, as a result of all this, from the early 90s, just giving a brief historical preview, in many countries, in many, particularly in Europe and in North America, and we have started to try to standardize the outcomes, all with the aim of assessing the quality of care that they were providing, with the aim to improve care. And so we have pioneering efforts of the Eurocleft, the Clinical Standards Advisory Group, which was in the United Kingdom in the early 90s, AmeriCleft, and ScandiCleft in the Scandinavian countries. More recently, the International Center for Health Outcome Measurement have come out with a standard set of outcomes. And because of the complexities that I have previously highlighted, a consortium came together all across the world to try to harmonize and identify which outcome measures we should consider as the most important and what times to assess them for patients with clefts, such that all over the world we would have a standardized measure. Even till date, standardizing these measures is still a challenge, but there have been some reports in the literature on standardization, and I will share some of them in the course of my presentation. Well, there are reports from different parts of the world, from Europe, from North America, even from Asia. In resource-limited environments such as in Sub-Saharan Africa and Nigeria in particular, we do not have too many reports on treatment outcomes. And that is an area where, and that is why presentations like these and others are important, to highlight areas that we can work on together as members of the team to report evidence, give evidence-based reports of the findings of the great work that we're doing in our different centers. Now, there are 8 different, according to Alori et al., this was in 2015, 2016, an international working group was set up with different cleft care specialists from different parts of the world. Unfortunately, there was no African in that team, but it doesn't affect the outcome of their results. They came up with 8 domains for cleft care, and this is Alori et al. It talked about eating and drinking. Eating and drinking was a domain, and outcome measures that were looked at were body weight. I know that at our center in Luke, there's currently a study going on feeding, looking at different feeding types and body weight. So body weight is an outcome measure for children with clefts. We know that normally before we go to surgery, we want the child to be, the rule of 10s, 3.5 kg, and all that. So those are simple outcome measures. Dental and oral health, that is a major focus for this presentation. Speech and communication, pathologic health, breathing, appearance, psychosocial development, and burden of care. These are 8 different outcome domains. For each outcome domain, you have outcome measures that can be assessed. For the purpose of this presentation and for the sake of time, I'm talking about only dental and oral health and appearance, or I can also refer to appearance as dentifacial aesthetics. Outcome measures for dental and oral health. Dental health outcomes. Dental health outcomes for measures with clefts are basically the same as those used for children without orofacial clefts. In measuring dental health outcomes in populations without cleft, basic things we look at include oral hygiene. There's a gingival index that has been developed by Low and Silnes, periodontal indices, and then caries index. Caries, which is the caries index, is the most widely used index in assessing oral health in general populations, and this is the same thing in patients in populations of children with cleft. So the DMFT and the DMFT index is the most widely used dental health measure. DMFT simply stands for decayed, missing, or filled teeth. This index records all decayed teeth, missing, or filled teeth as a result of dental caries. It's very simple and easy to use and quick to carry out. It simply involves an oral investigation of an oral assessment, intraoral assessment of the child in a well-lit area to identify any carious lesions, which often present as holes in the teeth. And if the child has any carious tooth, or any tooth that has been filled, or has lost any tooth, or had that tooth extracted due to caries, it is charted, and the combined number of decayed, missing, or filled teeth for that child will form the DMFT index. So it's possible to tell the caries exposure of a child or even an adult from the DMFT index. The capital DMFT is used for the permanent teeth, the small DMFT is used for the primary dentition. And several studies have shown that patients with cleft lip and palate are at a higher risk of caries and have a higher DMFT ratio than normal population. So the DMFT is the most commonly used dental health outcome measure. In terms of patient-reported outcome measure, the child oral health impact profile is a quality of life assessment tool, which is used to assess patient-reported the state of oral health of the patient based on the patient's own reports. And many studies have been done to compare the oral health quality of life of children without clefts and children with clefts. And children with clefts have been reported to have a higher burden and cleft due to the presence of clefts on their oral health related quality of life. Measures for assessing primary surgery and facial growth. This is where a lot of work has been done in terms of outcome measures in particular. Several systems have been described for measuring dental-alveolar relationships as an outcome measure for patients with cleft lip and palate. These systems are also able to assess the effects of primary surgery on facial growth. The timing for surgical closure of lip and palatal defects vary in different centers. The common period for lip repair being 3 to 6 months, while with the palate repair, it occurs between 6 to 18 months in different centers all over the world. So while early closure, and this argument is one that has gone on and that continues to go on across specialists, talking about early closure may favor speech, vision, and aesthetics, it may also result in scar tissue formation, which will restrict maxillary growth. Thus, outcome measures to assess the effects of surgery on maxillary growth largely focus on dental art relationships. Basically, all over the world, the argument continues to go on about whether you want to close cleft palate defects early or late. And the argument is that early closure will facilitate speech. However, that early closure could also impair if the surgery is not very invasive, or if depending on the type of surgery that is done. That is also what the surgeons argue about, that different types of surgical techniques may actually impair the growth of the maxilla. We know that in patients with clefts, the maxilla tends to be hypoplastic. Repair of the cleft palate defect, the scar tissue from that further inhibits growth, and so depending on the the impact of surgery, maxillary growth may be impeded. Now, what these indices that are assessing primary facial, assessing the primary surgery do is that they assess whether or not the surgery that was done in the cleft palate repair, whether it has negatively affected the growth of the maxilla, putting it in the simplest terms. And so, as a result of this, the study models of children with repaired unilateral cleft lip and palate can be assessed, and the relationships that exist in those models can be used to tell whether the primary surgery that was done was, quote and unquote, whether it had a very negative impact on growth or whether it had a favorable impact on maxillary growth. Many of the common indices that have been developed to assess this impact of primary surgery on growth are the Gosden rating, the 5-year-old index, and the modified Woodard-Bodinman index. The Gosden yardstick. This was the first widely reported outcome measure developed for assessment of the results of primary cleft surgery. It was developed in the Great Ormond Street, London, and Oslo, Norway. The Gosden yardstick was developed in 1987. It was devised using 30 sets of study models of 12-year-old children born with unilateral cleft lip and palate, and were assessed from the archives at the Great Ormond Street Hospital. The models were chosen to represent the full range of results from excellent through to very poor, and were ranked by 4 orthodontists from best outcome to the worst outcome. This slide shows the 4. So these are the standard models that are used for the Gosden yardstick. These models are the reference models for the Gosden yardstick, and it goes from group 1 to group 5. Group 1 shows that patients had an excellent or favorable outcome, that the surgical that the surgical repair of the palate in that patient ended up with a very favorable outcome. And as such, we can see the patient has a positive overjet, and the upper teeth are above the bottom teeth. Thus, the orthodontic treatment required for that patient is very minimal. For group 2, you have a good or favorable outcome. Group 3, you have a fair outcome or requires complex orthodontic treatment. For group 4, the outcome is poor. So each of these models from group 1 to group 5 are the standard reference models that are used for the Gosden yardstick. The key thing about this yardstick is that you have to be trained and calibrated in its use in order to be able to assess models of patients with unilateral cleft lip and palate, and to assess the outcome in terms of the impact of the surgery on maxillary growth. Each group 1 is excellent, group 5 is very poor. Patients with group 5 indicate that those patients will require orthodontic surgery, and that orthodontic treatment, very little orthodontic treatment can be done to correct the presenting occlusal relationship. The advantage of this index is that the patient study models are secured is used in early permanent dentition stage. It can assess anterior, posterior, vertical, and transverse factors in that order of importance. It has very good face validity and reliability. And the Gosden yardstick is the most widely used yardstick for assessing occlusal effects of primary surgery. However, it has its limitations. You can only use it in the late mixed dentition. So you can only use it for like 8-year-old to 10-year, ideally used for 10 to 12-year-olds, but you can use it for 8-year-olds as well. You need to be trained and calibrated for its use. It only is suitable for unilateral cleft lip and palate, which was what the reference models were made from. And so these are some of the limitations for its use. So based on the fact that the Gosden yardstick could only be used in children in late mixed dentition, others went ahead to develop an index that could be used at a younger age, and this led to the development of the 5-year-olds index. This was developed to provide an earlier measure of outcome. This is strongly determined by primary surgery. Arguments that were made against the Gosden yardstick were the fact that in an 8-year-old patient with a cleft, it is very likely that by the time the child is 8, you may be planning alveolar bone graft for that patient, and the child will undergo some form of orthodontic treatment. And once the child has undergone orthodontic treatment, we realize that those models no longer reflect solely the effects of surgery. And so it was argued that if we're able to assess the children at 5 years old, when it is very unlikely that they would have undergone any form of orthodontic treatment, we will better be able to assess the impact of surgery on maxillary growth. And that was what led to the development of the 5-year-old index. It is very similar to the Gosden index in the fact that you have 5 reference models that go from excellent to very poor. But like the Gosden yardstick, it requires calibration and training, and it can only be used for unilateral cleft lip and palate. This is a similar picture But the only difference here is that this study was done in 5-year-olds. The modified Woodard-Boddingham index, based on the limitations of the Gosling yardstick and the 5-year-old yardstick, that you needed to be trained and you needed to be calibrated, and the fact that they were age specific in terms of the age range that you could use them for. Some people went back and worked on the Woodard-Boddingham system, which had been developed since 1972, and they modified it to be able to correct some of those deficiencies they had observed in both the Gosling index and the 5-year-old index. The Woodard-Boddingham index is based on a cumulative scoring system where a palatal crossbite with respect to the opposing tooth is graded negative score, and a buccal crossbite is graded a positive score. So the Woodard-Boddingham index uses both upper and lower teeth and their position to grip the grades. This modified Woodard-Boddingham system, because it can be used at any age and because it does not require training and calibration, has been widely used. However, it also has its own limitations. This is a diagram showing the Woodard-Boddingham index. From the far left to the far right, you can see the scores at the bottom: -3, -2, -1, 0, and 1. In each case, you find out that let me take it better from the right to the left. On the far right, you find out that the upper incisor is ahead of the lower incisor. That's a positive score, and that's +1. Just on the left of that, you see that the upper incisor just touches the lower incisor, but is in front of it just slightly. That's a 0 score. And then you go, when they both touch each other edge to edge, as is seen in the third diagram here, that's -1. When the lower incisor is ahead of the upper incisor, which is a reverse of the normal, it's -2, but still makes contact. When it's far ahead, it's -3. So the more positive the score, it means that the more enlarged, or the better the expansion that has occurred in the maxilla, and that you have limited maxillary constriction. However, this index still has some disadvantages, in the sense that unlike the other indices, it doesn't take into consideration it weighs the transverse discrepancies as heavily as the anterior-posterior discrepancies, because it mainly takes into consideration only the transverse discrepancies. It doesn't take into consideration anterior-posterior discrepancies or vertical discrepancies, and those are very key. Anterior-posterior, vertical, and transverse discrepancies are all important in assessing the maxilla and the mandible. It only considers the transverse discrepancies. So the reason why people do not, and why the modified Woodard-Boddingham system, even though it's able to cover up some of the deficiencies of the Gosling and 5-year-old index, is that although it is more objective in what it measures, it is the features which it does not measure that make it a less widely used outcome measure of assessment. In Louth, in a center in Louth a few years ago, a study was carried out by one of our residents as part of our Part 2 fellowship exam to assess the surgical treatment outcome of patients using the modified Woodard-Boddingham method. This report is not yet published, but the findings from that study were very positive. Cephalometric analysis. A cephalometric radiograph is a standardized true radiograph of the skull. Cephalometric analysis have been used in several studies to assess the primary outcome of surgery. In many instances, what we use in cephalometric analysis are the A and B angle, because the A and B angle reflects the maxillomandibular relationship of patients. This is a picture of a cephalometric radiograph of a patient. The picture on the left in blue is the A and B angle, and on the right shows in its labial angle. The A and B angle is a skeletal measurement. In the past, a lot of emphasis were placed on just skeletal measurements in patients with clefts, but now a lot of more emphasis is being placed on the soft tissue profile. And so with cephalometric radiographs, we can assess the level of propination of the maxilla to the mandible, and we can also assess the soft tissue relationships of patients with clefts as outcome measures of both the surgical repair of the hard palate and even the lip repair as well. More recently, more extensive cephalometric analyses are carried out to assess the soft tissue profile outcome of patients with clefts. The soft tissue assess analysis give a more accurate outcome measure of the cleft surgery, and indices such as the labial angle and soft tissue A and B angle can be measured. Higher and more accurate imaging techniques such as the cone beam CTs or 3D cephalometric radiographs are used particularly in the orthodontic treatment planning for these patients. More recently, we have the 3D imaging systems. In spite of all this, the cephalometric analysis also have their limitations. It is not ethically right to simply expose the patient to radiation, simply to measure treatment outcomes. And so many times when cephalometric analysis are done for patients with clefts, what we do at our center is that we send these patients for radiographic assessment prior to orthodontic treatment, which is a standard requirement for orthodontic treatment. And so those radiographs that we get from the assessment prior to treatment can also be used to assess outcome for other procedures that have been done. The other challenge with disadvantage of cephalometric analysis is the fact that identification of maxillary landmarks may also be difficult because of the cleft defects. You may have some difficulty in assessing some radiographs because the area of the maxilla is not very clear. This is a cephalometric research paper that was done, one of the earliest reports that were done in youth in the early 80s that compares cephalometric findings in a study that was done and published in the Cleft Valley Journal, where cephalometric findings in normal Nigerian adults who did not have clefts were compared with adult patients with untreated clefts. Assessment of dentofacial aesthetics. The major outcome measure of assessment for dentofacial aesthetics in children with orofacial clefts is the assessment of the nasolabial aesthetics. Indeed, nasolabial appearance is one of the most important outcome measures of success in the assessment in patients with cleft lip. Nasolabial aesthetics is assessed can be assessed in two main ways. You can assess it directly in the clinic, and you can assess it by viewing the patient one-on-one, and they can also be assessed indirectly via photographs, videotapes, projected films, black and white drawings, etc. The assessment may either be quantitative or qualitative. Qualitative assessments are subjective. They use scales, indices, scoring systems, and rankings, while the quantitative methods may be more objective. They use linear or angular methods. Now, to date, there are 5 principal scoring systems that have been very commonly used worldwide. These include the Asher-Magdate system, the VLS system, the craniofacial proportion system, the aesthetic index, and the cleft lip evaluation profile index. Very recently here in Nigeria, 2 of our colleagues who are also members of the cleft team, Adesoye and Akadri, developed a visual rating chart in assessing cleft outcomes for lip repair and also the assessment also include an assessment of palate repair as well. And in their report, they reported that they wanted to correct the shortcomings of previous systems, which did not clearly indicate the deficiencies that occurred in those defects in their ratings. Now, all of the above listed scoring systems are clinician-based. There are also more recently now patient-reported outcome measures for assessing outcome in nasolabial aesthetics in patients with cleft. So we have things like the cleft Q, jaw, cleft Q face, jaw, and dental, which are patient-assessed outcomes. Now, I will refer back to the Asher-Magdate system. The Asher-Magdate system is the most widely used system for assessing nasolabial aesthetics worldwide, and I will expatiate on that a bit more. It's an indirect system that uses a qualitative scale to assess cropped photographs of the repaired nasolabial area in patients with repaired cleft lip and palate. The cropped photographs are used to reduce the influence of surrounding features such as the hair and the eyes. What they found out is that in assessing the photograph of patients with repaired cleft lip, if you left the features of the hair and the eyes, that it affected the outcome assessment so much because the hair and the eyes have been found out to be the #1 sign of beauty on the face. So the hair and the eyes can impair the assessment of the lip repair and the nasal outcome, which you want to focus on for cleft patients. So the photographs for these patients are standardized photographs are taken and they are cropped to eliminate the eyes and the hair of the patient. It's a 5-point scale, which goes from 1, excellent appearance, to 5, a very poor appearance. This photograph shows the cropped frontonasal and lateral views that this scale is used to assess. This scale has 4 measures. It assesses nasal form, symmetry of the nose relative to an imaginary vertical midline constructed at the midpoint between the inner canthi, shape of the vermilion border, and the nasal profile, including the upper lip, and that's what the photograph on the right is assessing. And so the interesting thing about the Asher-Magid scale is that you can actually compare nasal form. You can use even is a component analysis. You can use one component and compare one component across different centers. So you can compare nasal form of all the patients in center A and use that value to compare with all the patients in center B. And you can use it as a composite scale. You can actually combine all the values together to assess the nasolabial aesthetics in general for different centers or for different patients. Very often, this assessment is carried out by a panel of experienced operators in cleft team. So it's often a team approach to judging the outcome of the patient. Very often, you can have an orthodontist, a cleft surgeon, and a speech pathologist. But a recent study that was carried out has shown that even when they allowed non-trained cleft specialists to rate the outcome using the Asher-Magid scale, they found out that there was a strong correlation between their assessments and the assessments of the experienced operators, which showed that the scale is not selective only to experts being assessors, that lay people can also assess the scale once they are told the different options in the scale and they are shown photographs of patients to assess. And they do not require any extensive training in order to be able to properly assess outcomes of nasolabial aesthetics. This scale has been used and validated in a large number of multi-center clinical trials, assessing the outcomes of cleft and palate patients. Patient-reported outcome measures. I had alluded and mentioned this earlier on. Before I even go to patient-reported outcome measures, it's important to also mention that because the scope of outcome measures, even for the 2 areas I'm talking about, are quite extensive. I have intentionally not included certain things, and I'll touch on them if I still have some time. But it's important to know that alveolar bone grafting as well, we can have outcome measures for alveolar bone grafting, and some skills have been developed that assess outcome measures for patients after alveolar bone grafts have been done. The most widely used scale is the Kinderland scale. Patient-reported outcome measures. Now, patient-reported outcome measures are gradually becoming a very important aspect in the assessment of treatment outcome for patients with cleft and palate. In the words of Donna Bidian in 1996, patient satisfaction should be the ultimate validator of the quality of care. In earlier national and regional outcome studies, little emphasis was placed on patient satisfaction with the care received. But in the clinical study advisory group study in the UK, they designed questionnaires to assess patients and parent satisfaction with different aspects of treatment received. Parents and 12-year-old children were asked to rate their satisfaction with various aspects of clinical outcome, including speech, appearance of the teeth, the lip, and the nose, using a Likert scale. And these ratings were categorized into very satisfied, satisfied, and dissatisfied. And so in the CSAC study, which was the study done in the UK, which was one of the earliest outcome studies done, those questionnaires were included. But more recently, as people understood the importance of quality of life, more recent studies have been done to develop more sensitive tools to assessing quality of life and the patient's perception to treatment outcome. The Cleft Q is a standardized validated tool to assess patient satisfaction with dentofacial appearance, function, and quality of life. This Cleft Q scale was done by an international group. They involved patients from Canada, from the United Kingdom, from India, and thankfully there are patients from Kenya as well here in Africa, Ethiopia, and I think the US. And so patients were asked questions on different aspects of how their cleft conditions affect, how they were affected by having clefts, how it affected their quality of life. And so they used that to develop a questionnaire, the Cleft Q, which this was reported in literature in 2017, and is gradually gaining ground as a very strong tool for assessing patient-reported outcomes for specifically developed for patients with clefts. It looks at three main areas: dentofacial appearance, function, and quality of life. It is used for 8 to 29-year-old patients. It can be used to assess the jaw, teeth, eating, drinking, psychological function, social function, school function, speech distress, and speech function. These 9 skills are also included in the International Consortium for Health Outcome Measurements, standardized outcome measurements for patients with cleft lip and palate. So what challenges do we face here in terms of outcome assessment? Unfortunately, we don't have a very good record-keeping culture, and this ties also into our audit culture. Limited resources and inadequate personnel. Not all centers have a complete multidisciplinary team. For instance, it's difficult to carry out some of these assessments without an orthodontist on the team. And even for some of the teams that have all the specialists present, you need a team approach to care in order to be able to carry out assessments, some of these assessments that are required. Some people are also not, some of the measures I mentioned before require some level of training and calibration, which may be lacking, but it's not difficult to achieve. Lack of data standards across centers. Thankfully, the SmartTrain STX allows us to standardize reports and treatment outcomes to an extent, and that is a source from which we can get baseline different treatment outcomes. For instance, our lip repair and all that. However, we see there's a need for standardization of data standards across centers so that everybody is collecting specific data at particular points in time, and this we can integrate to improve the quality of care that we provide. So outcome studies form an integral part of the comprehensive cleft care. The findings from these studies help clinicians to assess the quality of care provided and also highlight areas for improvements in team care. These studies also provide a basis of comparison of cleft care provided in Nigeria and sub-Saharan Africa with other parts of the world. Ultimately, outcome studies will guide us to provide the best quality of care to our patients, while bearing in mind the peculiarities of our environment. So what recommendations can I share? I think outcome measures assessment should be integrated into the comprehensive cleft care currently being provided at several centers in Nigeria and the entire West African region. Cleft centers in the country should run audit clinics and also ensure that adequate treatment records of patients seen are maintained. There is a need for comparison and collation of cleft outcomes across centers on a regional and national level, with the aim to learn from one another and also improve on the quality of care provided. The possibility of developing Nigeria cleft, West Africa cleft, Afri cleft, doesn't really matter what we call it, but to develop regional, national bodies that are focused on reporting, sharing our using evidence-based studies to reflect.
Dr. Sikwe, can you begin to round up now?
I'm actually done. I'm done with it. Thank you. So there's a need for us, when you search the literature, studies from this part of the world, particularly in terms of outcome, are missing. There's a need for us to harness, use evidence, provide evidence-based reports of what we are doing, because we are doing a lot of good work across our centers. Because there's also a lot that the world can learn from what is happening in Nigeria, in West Africa, and Africa in terms of our outcomes for patients with clefts. Thank you very much, and I'm grateful to other members of my cleft team. Thank you.
Thank you. Thank you very much, Dr. Isikwe. Dr. Isikwe has been our lecturer today, and he has given this lecture in collaboration with the Nigerian Association of Orthodontists and SmileTrain. The lecture has been quite informative and educative. Again, if you have questions, please, we'd like you to please put these questions in the Q&A box, and then we'll have the comments in the chat box. Dr. Sikwe has given us a lecture on the outcome measures of assessment for oral health and dentofacial aesthetics in patients with orofacial clefts, and has gone through quite a number of methods for assessment. Now, I'll just look in the Q&A box for any question. And there's just one question here for Dr. Isikwe. And this question is by Barbara Delarge. She says, thank you for this presentation and the emphasis on the need for outcome evaluation. According to your experience, would you say that pretty much every patient with a cleft would need orthodontic work done? She's asking that question. Would you say from your experience that pretty much every patient with a cleft would need orthodontic work done? If not, what is the percentage of patients who will really benefit from orthodontics? Over to you, Dr. Isikwe.
Yeah, I think that's a very good question. Orthodontic care for patients with clefts is something that is a process that happens from the moment the child is born. So when that child becomes an adult, in fact, the orthodontist on the cleft team is probably the orthodontist and the surgeon are those specialists that see the patient from birth to adulthood. So it is not all cleft patients that may require the need of an orthodontist. However, most cleft patients, I probably would say about 90% of the patients. It depends. The patient with unilateral cleft lip without the palate may, depending on how the lip appears at birth, if it's not a severe defect, but we talk about pre-surgical infant orthopedics, and we find out that pre-surgical infant orthopedics is done for children when they are born, and that can correct the nasal form in a child with cleft lip. So I would say that every child with a cleft will require the input of an orthodontist. Whether that child will require orthodontic treatment will depend on what the child is presenting with. So I would rather say 100% of the patients that have clefts should be seen by an orthodontist for assessment. And from my experience, most of these patients, about 90%, will require some form of orthodontic care or the other over the course of their life, from the moment when they are born till when they complete treatment as adults.
Maybe I would say that maybe the only exception might be patients with just the cleft lip deformity alone. But as long as it involves the palate, the alveolus, there would just definitely be a need for orthodontic intervention at one time or the other. Thank you very much for that question. Any more questions? Please, can you put your questions in the Q&A box? Maybe as we wait for more questions to come, we can look at some of the comments. Well, a lot of the comments have been to commend Dr. Isikwe for a detailed and illuminating presentation. A comment here says, it's time for us to audit surgical outcomes, saying that this is long overdue. Well, I believe for surgeons on the house or on this platform, that's the challenge for us. It's time to audit surgical outcomes. And this is from Professor Butali, said this is long overdue. Again, the question is being put here. Actually, we did say that we should have our questions in the Q&A box. Maybe this is a comment. And it says, thank you, Dr. Isikwe, for your presentation. Can you highlight the importance of age in measuring outcomes in cleft lip and palate patients? This is from Dr. Tokunba Adeyemi from Faculty of Dentistry, University of Ibadan. This should have been in the Q&A box actually, but again, because of, we still have some more time, I'm reading this out from the chat box. So can you highlight the importance of age in measuring outcomes in cleft lip and palate patients? Over to you, Dr. Isikwe.
Yes, thank you, ma'am. Thank you, Dr. Adeyemi. It's a very good question. The Because of the limited amount of time for this presentation, I couldn't throw more light on that in particular. Indeed, the International Committee on Health Outcome Measures actually specifies that outcome measures, specific outcome measures should be measured at a specific age. I'll take the 5-year-old index as an example, particularly which is relevant to this presentation as well. At the age of 5, in many centers in the UK, the child has the model taken, and they use the 5-year-old index to assess the quality of primary surgery that the child has done. There's an oral assessment for caries, so the DMFT index of the child is taken. There's a speech assessment done, and at the age of 3.5 years, there's a weight of children with clefts are taken, and there's a growth chart to monitor whether that child is eating and feeding well. So age plays a key role, and in fact, in outcome measures assessment, there are specific outcomes that are measured at specific ages, and I will use the assessment of primary occlusion and primary surgery as an example. You do it at age 5, you do it at age 8. It's recommended you can also do it at 12 years old as well. So it's a continuous assessment, and the same thing goes for other outcome measures. I've only talked about 2 domains in this presentation. For all the other domains, there are specific times for assessment. It is by making the time specific, because the child with the cleft is going to go through, is developing over a period of time. The only way we can compare our outcomes is if we all measure those outcomes at a common period in time. And so, for instance, in the UK, they use 5-year-old as their index, and they have the 5-year, everything about the cleft patient at 5 is compared, and they use that for planning treatment. So age is very important. Age is very important.
Thank you very much for the response. Right now, there are no more questions in the Q&A box, and comments generally are commending Dr. Isikwe for a very informative and detailed presentation.